In this video, a comprehensive exploration of the MCQs and questions related to this case study. By staying engaged, we will dissect the case study thoroughly and ensure you are well prepared to tackle these questions. A businessman went to a party in which much food and alcohol was consumed. Next morning, he wakes up with severe excruciating pain in foot around ankle joint and big toe. He rushes to hospital. On examination, his ankle was swollen, severely tender, stiff and felt hot to touch. His blood investigations are as follows. Random blood sugar is 120 mg per deciliter. Serum urea 32 mg per deciliter. Serum creatinine 0.7 mg per deciliter and serum uric acid is 9.6 mg per deciliter. These are a set of MCQs. Feel free to pause the video and attempt to answer them. Later, I will present the same MCQs again and you can give them another shot. Case related questions are: what is your probable diagnosis? Enumerate the primary and secondary causes of the condition. What is the relationship between alcohol consumption in this case? How would you make a definite diagnosis? What are the treatment modalities in this case? Key points in this case are: first is primary symptoms. The patient experiences pain in the ankle joint and the big toe is affected. Second is patient history. The patient consumed alcohol on the previous night. And third is laboratory finding. The patient's serum uric acid level is elevated at 9.6 mg per deciliter, whereas the normal range is less than 7 mg per deciliter. This is a case of hyperuricemia. Hyperuricemia is the most common disorder of purine metabolism. Purines are adenine and guanine. Prior to go into the specifics of this case, I have created an interesting video that simplifies purine synthesis using a mnemonic. Click on the card or within the video description, you will find the link to explore it. This is the purine ring. C4, C5 and N7 in the purine ring originate from the amino acid glycine. N1 is derived from aspartate. N3 and N9 are from glutamine. C6 comes from carbon dioxide. C2 and C8 are from folic acid. So the amino acids involved in purine ring structure are glycine, aspartate and glutamine. Other substances are folic acid and carbon dioxide. Ribose 5-phosphate is derived from the HMP hexose monophosphate pathway. It serves as the initial compound for the synthesis of purine nucleotides. Ribose 5-phosphate undergoes a conversion to phosphoribosyl pyrophosphate (PRPP). This conversion is catalyzed by the enzyme PRPP synthetase. The pyrophosphate group is transferred from ATP to ribose sugar. Then in next step, the transfer of amide group from glutamine to PRPP and form 5-phosphoribosylamine. Enzyme is phosphoribosyl amidotransferase. Remember these first two steps of purine synthesis. Now we will see degradation of purine nucleotides. Enzyme nucleotidases act on nucleotides AMP, IMP and GMP, by which phosphate groups are removed to form corresponding nucleosides adenosine, inosine and guanosine. Adenosine is deaminated to inosine by the enzyme adenosine deaminase. Purine nucleoside phosphorylase enzyme hydrolyzes and removes ribose 1-phosphate and form hypoxanthine from inosine and guanine from guanosine. Hypoxanthine is converted to xanthine by enzyme xanthine oxidase. Guanase or guanine deaminase enzyme deaminates guanine to xanthine. Then xanthine oxidase enzyme acts on xanthine to form uric acid. Xanthine oxidase found in liver and small intestine. It is a metalloenzyme, contains FAD, molybdenum and iron. In humans, the total amount of nitrogen excreted as uric acid is very little because human beings are ureotelic. The birds, amphibians and reptiles are uricotelic, and the lower primates and other mammals have the enzyme uricase which converts uric acid to allantoin. Now we will see the causes of gout or hyperuricemia. They are divided into two parts, primary and secondary. First we will discuss about the primary causes that mainly increases the PRPP level which channel into formation of purine nucleotides and catabolism of it causes hyperuricemia. First is elevated PRPP synthetase activity. In this scenario, the enzyme PRPP synthetase is insensitive to feedback inhibition by ADP. Next is elevated phosphoribosyl amidinotransferase activity. In this scenario same, the enzyme phosphoribosyl amidinotransferase is unresponsive to feedback inhibition by AMP, GMP and IMP. Next is deficiency of HGPRTase activity, hypoxanthine guanine phosphoribosyl transferase. It's a salvage pathway enzyme. This scenario leads to increase in PRPP level. Next is glucose 6-phosphatase deficiency, von Gierke's disease, a glycogen storage disease. Glucose 6-phosphate is not converted to glucose in the absence of enzyme glucose 6-phosphatase. Glucose 6-phosphate is diverted to HMP shunt leading to formation of ribose 5-phosphate which leads to increased formation of PRPP, leading to increased purine synthesis and its degradation to uric acid. Next is increased glutathione reductase enzyme which increases NADP level which in turn increase HMP pathway. So these are the primary causes of gout. Now we will see secondary causes. They are again divided into two parts, causes due to reduced excretion of uric acid and causes of increased production of uric acid. First we will see causes of reduced excretion, that includes renal failure, treatment with thiazide diuretics which inhibit renal tubular secretion of uric acid, lactic acidosis and ketoacidosis due to interference with tubular secretion of uric acid. Now causes of increased production of uric acid, that includes rapidly growing malignant tissues, leukemia, lymphoma, polycythemia, cancer patients on radiotherapy or chemotherapy. This is due to tumor lysis syndrome which increases cellular turnover. Excessive tissue damage due to trauma and raised rate of catabolism as seen in starvation. Now we'll see the relationship between alcohol and gout. The main reason for hyperuricemia in alcoholics is the increased production of NADH during alcohol metabolism, which causes the conversion of pyruvate to lactate. The lactate then can inhibit the transtubular transport of uric acid with the production of hyperuricemia and causes decrease in uric acid excretion. Gout, a condition characterized by the deposition of urate crystals, manifests due to the limited solubility of uric acid in water. Specifically, urate solubility decreases at lower temperatures. Consequently, these crystals tend to accumulate in cooler regions of the body such as distal joints of the arms and feet. Such deposit in joints, tendons and surrounding tissues is known as tophi. This results in inflammatory painful joints known as gouty arthritis. A typical gout attack is characterized by sudden onset of severe pain, swelling, warmth, reddish discoloration, and marked tenderness of a joint. The joint most commonly involved in gout is the first metatarsophalangeal joint, the big toe. Elevated uric acid excretion can result in renal calculi, kidney stones, and kidney failure. Gout attacks may be triggered by a high purine diet, means non-veg, and increased alcohol consumption, which leads to accumulation of lactic acid. Now we will see diagnosis of gout. First is estimation of serum uric acid. Normal is below 7 mg per deciliter. It will be increased in hyperuricemia or gout. You can confirm this by polarized light microscopy of synovial fluid. Synovial fluid of inflamed joint obtained by aspiration under topical local anesthesia. In gout, crystals of monosodium urate appear as needle-shaped intracellular and extracellular crystals. When examined with a polarized filter and red compensator filter, they appear yellow or blue in color. Here you can see that. Finally, now we will see the treatment options in gout. It includes dietary restrictions of purine, means non-veg. Then restrict alcohol intake. We have discussed this already. Then proben acid, which is uricose uric drug, which decreases the reabsorption of uric acid from kidney tubules. Next is allopurinol. Allopurinol is oxidized by xanthine oxidase to form alloxanthine, which is a potent inhibitor of enzyme xanthine oxidase itself. It is an example of suicidal inhibition, thereby prevents the conversion of hypoxanthine to xanthine and to uric acid, leading to decrease in uric acid levels. Non-steroidal anti-inflammatory drugs includes colchicine, salicylates, indomethacin, corticosteroid, etc. Lastly, uricase enzyme that converts uric acid to allantoin. So after this explanation, I am putting MCQs once again. Pause it and try to give answer again. So this is all about the case study of gout. Hope you like this video. If you do, then please like and share this video and also subscribe my channel. Thank you.